Hello, Darren, Annemarie and Peter. Thanks very much for joining us on this session. It'd be really extremely useful for our audience to have a quick overview of how fit for purpose the overall support structure in Scotland is for those with lived experience. So, Annemarie, would you like to have a little stab at that first?
Tokenistic at best. Lived experiences not valued or acknowledged in a way that I see recognised in other parts of the UK or even other parts of Europe. So from a structural point of view and from a system point of view, it's still very tokenistic. And, you know, most people with lived experience are getting a wee pat in the head or a very steered voice.
Yeah, it's a really strange one because, you know, obviously in Scotland we have such a higher drug death rate than the rest of the UK. So the actual systems that are in place in the rest of the UK, I believe, are better than what they are in Scotland. Although if you look at it from a policy viewpoint in terms of the UK current policies, the policies in Scotland are driven towards more a health response, you know, than the UK government. But simple things like point of contact in terms of the support services, you know, through organisations like Change, Grow, Live, We Are With You that are operating south of the border. If somebody turns up to those organisations, they can get assessed if they're using street drugs and get onto a prescription automatically straight away. Whereas if they turn up to these services in Glasgow or Edinburgh, they get assessed, they have to wait, they get sent to the NHS for a further assessment, and then the NHS are so risk adverse in their prescribing procedures that it sometimes doesn't even manage the illicit drug use to the point where they can stop using illicit substances. So yeah, our support systems in Scotland are certainly lacking in terms of delivery, and also in terms of, you know, the impact that people who have personal experience of drug use have on the decisions that are made.
Policy without lived experience is like a toilet without a cistern, you know. Like every now and then you have to flush away the crap, you know, and in public policy the crap is all of the circular, often baseless assumptions that develop among sections of the population who have no direct experience of the issues over which they preside. So historically, lived experience has functioned as a way to offset that. You know, if you look at the Beveridge report, part of the basis of that was hundreds of interviews conducted in the 1930s by the state to investigate the long-term impact of unemployment. And that's what partly informed the very specific tailored welfare system that emerged from that. We've moved away from that and we've moved more to a kind of neoliberal form of lived experience, which is about wheeling out one media-friendly person to talk about their subjective, highly revised interpretation of what they think has happened, which never really deals with systemic contextual factors. And this then authenticates organisations in the eyes of the power structure, who are then furnished with more and more money and more funding for producing more and more failure.
We've got 5 organisations that play a significant role in drug policy. We've got the UK government, the Scottish government, local authorities, the Scottish Health Service and the wider medical and mental health services, and finally the police and justice system. Taking each in turn, if we can, I'd like you to kind of explain how those with lived experience are involved in those areas and what changes you'd like to see. Darren, is it okay if we start with you, and would you mind looking at the Scottish government?
Yes, absolutely. I think that the Scottish government, perhaps more so than the UK government, has at least attempted to address issues of proximity, low proximity, i.e. the further a decision maker is from the phenomenon or the event that's occurring, the less likely that they're going to develop the vital kernels of information that better inform their view of what's happening. And so if you look at the care review, for example, this was an attempt to draw a line under our very patchy care system. It's not really a system, it's lots of different systems all clogged together. There's no continuity between the systems. What's allowed in one local authority is not allowed in the other. Kinship carers were all receiving different amounts of money and all being underpaid for the service that they provide when compared to foster carers. And so the care review attempted to address lots of different aspects of the care system by placing people with care experience at the very heart of the discussion. Now, whatever the recommendations of that are and however they're implemented is a different issue. But, you know, there has been an attempt there to recognise, not just because of the moral issue or because of the optics of not having lived experience, but because of the very practical level of knowledge that people who have witnessed something and experienced something up as close as you can possibly be bring to social policy formation and analysis. I think that we need to start moving in that direction when it comes to drug policy across all of the different areas, because obviously we all represent our own sandbox in terms of recovery movement, harm reduction, the broader poverty, social exclusion issues, criminal justice, and so on and so forth. But I think you need that comprehensive overview of how it all pieces together so that we can actually look at replumbing the entire system gradually in the hope that it would produce a better output for everybody.
Yeah, the policing and criminal justice system's not really changed, I think, from my time as a street level drug user. I remember being arrested for simply how I looked, and then thrown in a police cell, and kept in and up to court, and placed on probation orders, community service orders, periods of time in prison. And it's not really changed. If we look at the criminal justice system now, 1 in 4 people who are currently sitting within UK prisons are in there for street level drug use. We're not talking about people who are involved in the concern or supply of substances. We're talking about purely street level drug use, and it's absolutely insane. The criminal justice system is still geared towards that, and it's unfortunate in Scotland, that we recognise this as a health issue, and the Scottish Government recognise it as a health issue. But ultimately, when we've got the Misuse of Drugs Act, which is 50 years old on the 27th of May this year, still determining how police are, can have to actually police the situation in terms of drug use. There's nothing that the Scottish Government at this point can really do to change that, and that lies out with the hands of the Scottish Government, as we've found out in recent months through the Lord Advocate's inability to address things like overdose prevention facilities, which is just a basic form of harm reduction, but lies within his power as the senior Scottish law officer. So the criminal justice system, we talk about things like smart justice, we talk about things like diverting people from prison sentences into treatment and rehabilitation services, but it's just not happening at the moment. I regularly see people walking out of prison, coming into Glasgow city centre to score drugs, and coming and injecting heroin or cocaine in my facility.
How do you feel the UK government treats those with lived experiences in relation to how we're doing that in Scotland at the moment?
Well, that's the paradox I think I've already spoke about a couple of times. The UK government are all still for criminalising drug users. Therefore, they believe that breaking up county lines and supply chains is actually going to impact the overall sort of crisis that we've got. I mean, this crisis, we often think about it just as a Scottish crisis. I think because of our drug death levels being so much higher than the rest of the UK. But if we add it up and we look at the UK as a whole, there's 16 people on average dying across the UK on a daily basis from preventable drug-related deaths. So it's been proven for generations now. Like 50 years this Misuse of Drugs Act's been in place, been trying to do the same thing over and over and over, and it's not working. But it still sits with the demographic and the narrative of the war on drugs that's been inflicted on us since 1970, 1971, since President Nixon stood up and said we need an all-out offensive war on drugs. That's the narrative that has been fed into our heads for all those years. Nancy Reagan Ronald Reagan, Margaret Thatcher just say no, drugs are bad. Drugs are not going away. That's the simple reality of it. We need to re-identify and we need a complete overhaul of how we're dealing with this issue. It needs to change. And the Tory narrative and their voter base still believe the narrative that's been fed to them for generations, that drugs are bad. Get everybody off drugs, that's the solution. And it's clearly not. If you look at countries that have had drug death rates that are as high now as what Scotland's got, with massive HIV infections and outbreaks and hepatitis C running riot, what they've done is they've introduced a safe supply of prescription medication to get people off of illicit substances, to keep people safe and protected, and then offer people residential rehab, pathways to social psychological support, health and welfare, all these wraparound services that need to be included. Everything needs to come together. We need the best harm reduction and the best social economic policies to drive change for the future.
We do need whole system radical change. There's no doubt about that. We have to remember that the root causes here, for the most part, people suffering from addiction, we're talking about poverty and despair and inequality. So our services as they currently stand are not fit for purpose. There's no doubt in my mind about that. They often work in isolation, conflict and competition with each other, which is incredible. And what we call treatment in the UK is actually harm reduction interventions, which are extremely valuable, but they're not treatment. They can prevent overdose, but it's not a long-term treatment to overcome addiction. It's merely managing symptoms. And, I wouldn't advocate for money to be taken away from any of these HR interventions, such as methadone or anti-abuse or heroin-assisted treatment or drug consumption rooms, safe injecting facilities. What we would advocate for, though, is the same type of investment into helping us get off drugs and alcohol, for instance. So, we've got a massive problem in Scotland in particular with alcohol, but we very rarely hear about it. Since lockdown, sales have went up by almost 40%. So there's a massive imbalance in not only in how we invest in so-called treatment services, but just our collective denial around how big the problem actually is. So for us, it's not enough to just focus on helping people stay alive. There's so much more available. As people in recovery, we're capable of so much more if we're supported to get well. And to front load the whole system with only harm reduction initiatives is an imbalance that is starting to be addressed in Scotland after 2 decades of austerity and funding and services being degraded and investment being pulled. So I believe it's actually morally wrong not to help us end our own suffering, and it's morally wrong to not help us get well.
Darren, Peter, do you have any views on treatment and intervention?
My experience in the past, and I know that things have changed slightly, my own drug use accelerated when Valium and diazepam and all that was still readily available at the GP. So all you had to do was go in and say the right things and play the right mood music, and you would get quite a substantial prescription of drugs. Because at that time, a lot of health professionals were only able to diagnose the symptoms that you were presenting. And I was turning up hungover, depressed, talking about hallucinating, hearing voices, and then being sent down a rabbit hole with an entourage of mental health professionals who couldn't identify that the central problem that I was dealing with was the corrosive mental, physical, and spiritual effects of inebriation on a daily basis. And actually for me, and this is just my experience, I was given drinking diaries, I was given anti-abuse, I've done non-residential treatment, I've done residential treatment. And actually the thing that really got my head in the game was just being around other people who had solved the addiction problem by abstaining from drugs and building certain principles into their life that allowed them to clear the emotional cache of resentment and anger and frustration that can build up over time, that can sometimes then create the conditions for you to think having a drink or a drug is a good idea. Now, that was my experience, and all I would like to see is that I would like to see that sort of recovery is prominently promoted and pursued as all the others, you know, because I think most people understand harm reduction. Everybody in Scotland knows what methadone is. Nobody really would know what you meant if you said abstinence-based recovery. And I think for me, it's important to sort of lay all the tools out on the table, and then people can find out for themselves what works for them at what time. Because I think just now services generally, and I've heard this countless times, and it's been my experience as well, often because of the lack of accountability and the great sway that certain individuals hold within the sector, whether it's at the level of the front facing or whether it's managerial, people project their biases and prejudices about certain types of recovery onto people. So if I go into a place and I'm rattling, somebody takes a look at me because of the way I sound, because of the way I dress, and they decide I'm not the sort of person who can get abstinent. They decide that my life is better if I just do, you know, a 15-year stretch on some other drug. And then I embark on that course of treatment because I have no frame of reference for what's available. I have no choice. I'm not empowered in any way. I don't understand the language of officialdom. I'm not even aware that I'm being prejudged. Then, you know, it sort of, it recontextualizes what's on offer right now as something else entirely, which is a real minefield and lack of consistency across different areas and services and between different types of treatment.
Darren's absolutely right. And what we have is, you know, this false dichotomy of harm reduction versus abstinence, and it's dominated our field for as long as I've worked in it, which is nearly 20 years, you know, and people become very entrenched in one camp or the other, and you know, and that's human nature to do that, you know, to have a belief system that's, well, I believe in harm reduction and I believe in abstinence. And what Darren's pointing to there is not just a progressive middle ground, but it's a humane, person-centred approach whereby people have access to both all the harm reduction interventions that could be available, including safe injecting facilities, but also, you know, we know from the research that the majority of people who become overwhelmed with substance use or other behavioural addictions have experienced extreme trauma. So in order to heal that, and if people want to get abstinent and stay abstinent, there's a tremendous amount of perseverance, tenacity, and, you know, just skills required that often involved, more often than not, involve really in-depth trauma-informed care. And there's very few places at the moment, but I know we're making headway into investing in residential rehab, but there's very few places on offer that type of care and that type of support and that type of treatment is currently not that available in Scotland. But we have to be offering all of those pathways to recovery and not punishing people if they fail or if they get, you know, if they get stuck on one, or if you know, to allow them to choose what's right for them and to give them the choice and make sure that they are aware of the different pathways that might help them.
Great. And Peter, how do you feel about that choice that's available?
Yeah, I think there should be choice available and people should be presented with multiple sort of opportunities and pathways and be able to make informed decisions based upon their own experience. You know, that's what I did. You know, I was told, you know, I remember my mum coming to visit me in Young Offenders Institution at the age of 16, you know, looking at a sentence, thinking, crying across the table saying, you need to change, you're a drug addict, you're an alcoholic, you know, I mean, you need to do this, you need to do that. And people told me that for years, you know, that I needed to do X, Y, and Z, and you know, and it was all driven towards, back then, it was all driven towards, you know, me getting off drugs. You know, that's what my mum thought was the solution. That's what the doctors and the people that worked in the psychiatric ward that I would sign myself into every 6 months for another dry out, you know, to go and get Valium and Librium, and you know, and I think, you know, we do have this sort of the ongoing sort of fight in Scotland to just get basic choices for people. You know what I mean? That's the problem, that we don't have. I mean, we often talk about like harm reduction. We simply do not have the most basic harm reduction in Scotland. We don't have it. I mean, we've got space for 20 people currently on heroin-assisted treatment in a country that has the highest drug death rates per head of population in the world. We've not got any safer consumption facilities apart from an ambulance that's parked in Glasgow for 23 hours a week. You know, I mean, it's just not available. Benzodiazepines, which are running rife through the country. Darren spoke about them. In my day, I could go to the doctor and get enough benzos to keep me stable. You know, I wouldn't need to go looking for street drugs. If I was out there injecting heroin and crack cocaine in my groin, begging for spare change like I was 20 odd years ago just now, I'd be dead, because I'd be out there using handfuls of street Valium that nobody knows what's in them. Over 800 deaths in 2019 were linked directly to illicit benzodiazepines. And if somebody goes to the doctor or goes to the NHS and says, look, I need 80 milligrams of Valium, I'm taking handfuls of street ones, 80 milligrams will be enough to stop me doing that, to keep me in a little bit of place of safety, they'll just get told, no, it's that simple. You're just not getting that. You know what I mean? You're not getting it. If we have range of choices available across the board, that's the only thing that's really going to change our drug death crisis. You know, because
I think it's interesting as well, isn't it, that when we think about drug treatment, we often think of, you know, what's described as the skid row addict or alcoholic, you know, so somebody who's completely on their arse. And that's traditionally who, you know, our drug treatment services or alcohol treatment services treat, in inverted commas. But I think if we think about Scotland as a whole, you know, and if we really do want to change our structures and our systems to deliver something of use and of value, we have to think about the, you know, hundreds of thousands of other people who are functioning. You know, they're not skid row, but they're leading lives of quiet desperation. You know, we're talking about social workers here, teachers, policemen, nurses who are addicts and alcoholics. But because our services are so geared towards, you know, the absolute crisis and centre of someone who's at their absolute rock bottom, those people aren't going to go anywhere near our services as they currently stand. And actually, I would argue that section of society who is leading that life of quiet desperation, completely addicted to painkillers or alcohol or other drugs, they've got nowhere to go within our current treatment system, because they're just, in fact, we're going to be burying a friend of mine recently who had her own business, and she was told categorically by the community addiction team that they couldn't do anything for her because she looked great and she had her own business, but she couldn't afford to go to private rehab. You know, she was doing well, but she wasn't doing well enough to go to rehab. So I think there's a wider conversation here about, you know, Scotland's cultural penchant for oblivion, you know, and how naturally how acceptable that is.
And I think, just to add quickly, that speaks to a broader issue which you'll find in along mental health lines, which you'll find when it comes to homelessness, and obviously there's a lot of interplay between those and the drug issue, and this is the high threshold to be regarded as in a crisis. So what the government does is it creates a bottleneck where people go and ask for help and they get pathed off and they get diverted around different services, or they have to deal with, you know, overwhelmed benefits agencies and that whole rabbit hole. and then they get to a point where they try and hang themselves from a lamppost, or they slit their wrists, or they jump in a river, or they overdose, and then suddenly the system becomes ready to deal with them. And that's, you know, extremely more costly. It's far more dangerous. And it just basically, it means you have to be literally on death's door, as Anne-Marie's indicated, before you'll be taken seriously. And that's just not a sophisticated way to manage these kind of issues.
I was working with a guy just at the start of lockdown there. He was begging throughout lockdown outside Tesco's. All the way through the first lockdown, I was going up. I was, taking him bits and pieces, dropping stuff off to him, trying to get him connected in with the service. He was smoking heroin, a previous injector of heroin. He could not even get an assessment. They said he was not high enough risk to get an assessment. The actual words of the senior manager was, "We're only assessing people who are pregnant or those that are injecting in their necks or their groins." And I'm saying, okay, so you're telling me that this guy has to go away and use drugs much more dangerously just to get an assessment to get on methadone, just for an assessment. And that's the issue of the problem. Most people, when they first turn up at a service, they first turn up for help and support. The first initial help and support that they ask for or that they want, certainly in my experience and the people that I'm working with, is a prescription to stop using street drugs. And when they're told no and they're sent away without getting on a prescription, the chance to engage with them and the chance to offer them things like residential rehab later on down the line is gone, because most often they may die or they'll just not come back. And that's why only 40% or less of people in Scotland currently sit in any form of treatment whatsoever, compared to over 60% in England and Wales.
We had a drug worker from the Glasgow addiction team get in touch with us this week about 2 new clients who had came forward. One was a man who worked in the rigs and had an opiate addiction. One was a young woman who worked as an administrator in a local office who had a painkiller addiction. They were both asking for detoxes, not rehab, and they were both offered methadone. When they said that they didn't want to take methadone, the worker, following the new standards within her team, said, detox can't happen. It can't happen immediately. There's a long waiting list for detox. But if you're refusing methadone, we may have to get in touch with the DVLA about your driving licence and social work about your children. To both this man and women, completely separate. Both of them functioning, both of them employed, just looking for help to detox, and they were threatened. So that goes back to the point about only 40% of people currently in Scotland who need help are in treatment. And that's one of the reasons why we've got, much higher death rates than England. Not only can you rock up at your local drug treatment service at Change, Grow, Live in particular and get prescribed something or enter a detox on the same day. It's laughable that we're stuck in the Stone Age. And what's more worrying though in Scotland is, like, whenever you challenge anybody about this, or you say to the services you're not doing enough job, they see it as a personal criticism. They don't see it as a way to improve, and they react like if you say, like, you can't leave someone on methadone for 15 years or 20 years or 25 years, as in some cases, they see it as you're criticising the methadone user rather than the methadone program. It's like this complete unwillingness to admit that we're not doing something right and that we need to change, and that if nothing changes, nothing changes. And there's this real pushback around change in Scotland. It's like, and the services themselves working in isolation and conflict and competition with each other, and the whole mentality being a closed shop. And I can say that, I can compare that to other countries in the UK where that just isn't the case, and that there's something quite sick and toxic about Scottish society's how it views addiction, and how it's like the guys and girls who are approaching services are the canaries in the mine, as far as I'm concerned. I think we've got a massive cultural problem, a massive societal problem, not just with alcohol or other drugs, certainly with gambling, porn, and everything else that can give you something, something to feel good for a few seconds. But yeah, I think there's a wider conversation to be had around this, a much wider cultural conversation.
There's a few things to pick up on there. Would it be fair to say that there's agreement about the need for more and earlier intervention?
Yeah.
Absolutely.
Okay. Across the board. Is that covered in any way in the Rights, Respect and Recovery Alcohol and Drug Treatment Strategy that the Scottish Government released in 2018? Or was that a much more of a narrower focus on the definition of drug use and drug harm?
I think Rights, Respect and Recovery is brilliant in terms of rhetoric. It probably says all of that and more, but there's a massive gap between policy and practice, as we all know. So even in 2009, we saw the road to recovery being first being implemented, and we saw that Darren used the plumbing analogy there. And what they described in the road to recovery was to turn a field of harm reduction workers into recovery champions overnight. So what that meant was to turn a field of plumbers into engineers overnight, and it was always going to fail, because they never retrained the workforce. They never changed the culture within the workforce. The culture currently within the workforce is that people need to manage their symptoms and they need to get stabilised. That's the culture, which in itself isn't a bad thing, but that's when the culture forgets that you can recover, or when the culture of addiction treatment never sees anybody who recovers, they lose hope. So culturally, our treatment system is stuck in the culture of addiction, and the culture of recovery is regarded as something that happens over there and that it's none of our business. And that we don't need to even be bothered with that, because our job is to manage the symptoms of addiction rather than help people, come out of addiction.
So have you got any thoughts on this kind of cultural importance around addiction and treatment of addiction?
Whether you're looking at suicide, whether you're looking at mental health, whether you're looking at alcoholism or homelessness, there are certain myths at the level of public opinion, which are actually implanted there by politicians who either don't know what they're talking about or who are deliberately trying to cultivate inaccurate conceptions of what social problems truly entail. If you look at how politicians' rhetoric at the beginning of this pandemic shifted from constant individualism, adversarialism, political tribalism, emphasising differences, stoking fear about immigrants and all of the rest of it, to suddenly this communitarian rhetoric, this looking on your neighbour rhetoric. For a few weeks at the start of 2020, we felt like we were living in a sufficiently kinder society. 1 million people signed up to become volunteers in a matter of days. We became preoccupied by how people around us were doing. Our whole behaviours, our mannerisms, our attitudes to the virus, our conception of the virus, our understanding of it, our sense of spatial awareness when we went outside, all changed just because politicians kept repeating a message over and over. So it shows that there's a link between the rhetoric that politicians deploy and the subsequent attitudes and behaviours that arise within the population at large. And unfortunately, it's going to be a long time before we see a politician going on television every day and saying pretty much every homeless person you see or drug addict you see is a victim of child abuse and neglect. People who are on drugs are suffering from a condition of mind and body, which means that at a certain point they become powerless over the choice to use, and they select from a narrow range of choices that most people can't even conceive of. If politicians came on TV and told the truth about all those things and applied the science to all those things, as they have done with COVID-19, and also deployed the sufficient financial resources, I mean, you could fundamentally reverse the polarity of this society within a decade. It's just that the will is not there, the knowledge is not there, and so the public fall back on the sense of powerlessness and resentment that they feel when they're confronted by homeless people all the time, and they're confronted by drug addicts all the time. They become angry because they can't do anything about it. So then a natural sort of explanation for them is that person's annoying, get that person to fuck that person. But it doesn't begin like that. It doesn't begin like that. It begins with a sense of, if I could help this person, I would, but I can't. The sight of them everywhere is just irritating the shit out of me.
And just picking up on that, Scotland's in a drug death catastrophe at the moment, and with the street valium, so-called street valium. And if you look at where those deaths are occurring, they're occurring in our poorest communities. So what is it that's happening in those poor communities that people think it's better to take your chances with a couple of blue valium that might kill me, than what is it that's driving people to that despair that they're willing to play Russian roulette with a couple of street valium? What is it that's so terrible about people's lives? And if we're asking politicians to do something, that's what we should be asking them to think about. What is it about what's happening in our poorest communities? How can we tap into finding out what that despair is about, and how can we actually help change that people are willing to play Russian roulette just to get out their own heads? What is it so desperate? What is it that's so bad that we're willing to die?
Darren, you mentioned that you believe that people want to help. Peter and Annemarie, Peter first, could you think what the people who are watching this section can do to help? Can you think of any kind of like direct calls to action for people who have been motivated by the conversation so far?
Question, like from a everyday sort of perspective, what is it that people can actually do? People, I think, question their motives and their morality around this type of stuff regularly, and especially having, my own personal experience, quite chaotic drug use, and having spoke to my family about that, and asked them how they are, and having become a parent myself, with 2 young kids, that's only really when I started to think about how that affected those around me, and how I really started to be able to like walk in other people's shoes and stuff. So it's a difficult one. I mean, for me, it's always about just having these conversations with your friends and your family around you. Like there's links out there. There's organisations like Transform Drug Policy Foundation, Release Drugs, Anyone's Child, who have some really great campaigns going on, activist campaigns where you can email your MSPs, email your MPs, ask them if they support real drug policy reform. Because when we talk about the bigger, wider changes across society for generations to come, it's about proper regulation, it's about taking away the chaos, the underlying chaos, and about investment in our local communities, like we've all spoken about. And I think everybody sort of starts to recognise and understand people that are primarily dying come from socially economic deprived areas, where they've not had opportunities growing up, where they have suffered. Sometimes, we talk about these like real extreme levels of trauma, like child abuse or, being physically beaten up, where trauma can be a lot more, just underlying in terms of not having enough to eat, not being dressed properly, going to school. Not having eaten in your house, these simple little things that create this like toxic environment to grow up in. So yeah, wider drug policy reform is definitely where I sit within this. Like we can do what we can now to support people right now, but for the generations to come, we need to see decriminalisation of drug use. We need to see it properly treated as a health issue where people are supported into treatment, and that's why I'm a major advocate of harm reduction, because people can't recover if they're dead. It's that simple.
One of the things about activist communities and people who mean to do good things is that they often come at things with a sense of confidence because they've already been involved in other campaigns and they've been active and participated. But unfortunately, sometimes what can happen is, you have a big influx of people who have become interested in an issue, and what they do is they'll unintentionally try to install their own hierarchy within a thing, or create their own thing within a thing that then becomes another thing to compete with all the pre-existing things. The best thing you can do is donate money to the campaigns that Peter's outlined, to Annemarie's charity. Go and find, there's a broad spread of organisations out there. You can donate money, you can go and offer to be a volunteer, helping out, doing logistical things. And this is a great opportunity, not only to demonstrate humility in the face of an issue evidently you don't quite have your head wrapped around yet, but also a very practical way to lighten the load for the people who've been on this campaign for a decade straight, some even more than that. So it's important, it's important to kind of basically go and ask those people, what do I need to do? Do you know what I mean? and that's pretty straightforward. I think that's a simple answer.
Yeah, definitely, look at Transform's website, come and see Faces and Voices of Recovery UK's website. Help us build an army of advocates, help Favour UK and Favour Scotland build an army of advocates to help people get access to the different types of treatment that might help them. We're specifically looking for people to help us write bids to build an army of advocates. I would say on a personal level, to talk about our difficulties more, to talk about our dad who had alcoholism, or our sister who's suffering, or, to talk about our own struggles with substance use or gambling or porn or shopping, whatever it is. And to talk about, those and that kind of stuff in an open and honest way. So as, we don't have to get to the point where we're in absolute crisis. We can reach out for help as individuals, and we can offer support when when we see a loved one who's maybe starting to rely or over rely on a substance or a behaviour. We can step in and say, I'm here. I'm here for you if you need to be connected. And by being vulnerable like that with each other, sharing our weaknesses and sharing our reliances or our dependencies with the people who love us or the people that care about us, is that vulnerability can actually prevent the need to be using whatever the substance is. The minute we reach out for help, we get relief. So if we can be a wee bit more open to talk about our own difficulties with our friends and with our families, that will certainly have a ripple effect on the rest of society.
And that's really powerful, Anne-Marie, because everyone can certainly do that, and there's not really many barriers to doing that. Anne-Marie, Peter, Darren, thanks so much for your time. We really appreciate it, and that's been a fantastic session. Thank you very much.